Periodontal pocket. Periodontal pocket is defined as the pathologically deepened gingival sulcus. Ideally speaking, the depth of gingival sulcus in the oral cavity is 0 mm, but since the ideal conditions are not encountered in the oral cavity, we have a normal depth of 2 to 3 mm. Gingival sulcus is defined as a shallow crevice which on one side is bounded by the tooth and on the other by the free gingival margin. The deepening of this due to some disease process results in the formation of periodontal pocket. The classification of pocket in general is based on two factors. First is the coronal growth of the gingiva due to increased bulk, and second is the apical displacement of the base of gingival sulcus. On this basis, we have gingival pocket, which is also known as the pseudo or the false pocket, and periodontal pocket, which is also known as the true or absolute pocket. In case of gingival pocket, there is no destruction of the periodontal structures. There is just an increased bulk of gingiva, which results in the formation of this pocket. However, in case of periodontal pocket, there is actual destruction of the periodontal structures, which results in the weakening and loosening of teeth, followed by the exfoliation. The periodontal pocket are further classified, first on the basis of relationship of alveolar crest with the pocket base. On that basis, we have the suprabony and the infrabony pockets. In case of suprabony pocket, the base of sulcus lies coronal to the crest of alveolar ridge and shows a horizontal pattern of bone loss. So the bone loss occurs over here. However, in case of infrabony pocket, the base of sulcus lies apical to the crest of alveolar ridge. So there is vertical pattern of bone loss which occurs in this manner. Now, second, based on the number of tooth surfaces involved, we have the simple, compound and complex. In case of simple, only one tooth surface is involved. In case of compound, two tooth surfaces are involved, and the depth, which is greater, is taken to be the actual depth of the pocket. In case of complex, all the tooth surfaces are involved and the extension occurs up till the furcation area. Third is based on the depth of pocket, we have the shallow and deep pocket. Shallow is wherein the depth is less than 5 mm, and in case of deep, it is more than 5 mm. Pathogenesis of periodontal pocket. Normally in the oral cavity, a few bacteria are present which induce the release of chemotactins, which in turn cause the migration of neutrophils from the blood vessels into the connective tissue and then into the sulcus, crossing the epithelium. Since this migration occurs in small numbers, we have abundant time for the epithelium to recuperate. However, when there is plaque accumulation which contains a lot of bacteria, this in turn results in the release of large amount of chemotactins which cause the release and migration of neutrophils from the blood vessels into the connective tissue and finally into the epithelium. This large transmigration results in the damage to the epithelial interface. Next up, the fibroblasts, neutrophils and the macrophages, they release matrix metalloproteinases, also known as the MMPs, and they cause the conversion of collagen into small peptides. At the same time, the fibroblasts, they extend their processes into the fibers present at the ligament-cementum interface and destroy them. The destruction of fibers by both the processes results in the changes in the apical portion of gingival epithelium. There occurs the formation of finger-like projections, and at the same time, when the bacterial count in the sulcus becomes about 60%, the fibers lose their cohesiveness, followed by the detachment of the coronal portion of the epithelium from the tooth surface. Simultaneously, there is the extension of the junctional epithelium along the root surface, and this occurs only due to the presence of the viable cells. And finally, there occurs the pocket formation. One point to be noted here is that in case of anug, there are no viable epithelial cells, hence they do not show pocket formation but ulceration. The contents of the periodontal pocket are derived from three sources, which are the tooth, gingiva and the oral cavity. From the tooth, we have the debris, toxins and enzymes, and microorganisms. And from the gingiva, we have the gingival crevicular fluid, neutrophils, and desquamated epithelial cells. And from the oral cavity, we have the saliva and food remnants. Occasionally, pus may also be present, which consists of degenerated cells and bacteria, fibrin, and serum. The clinical features of periodontal pocket. First, the symptoms. These include the pain. The pain can be localized or radiating or gnawing in nature. There's itchiness, foul taste, loose tooth, and sensitivity, which is due to the exposed cementum. The signs include, on probing, there is bleeding and exudation of pus. There is the presence of bluish-red martial gingiva and a reddish-blue vertical zone extending from the mucogingival junction up till the alveolar mucosa. Due to the destruction of attachment apparatus, there is also the presence of mobile tooth, which may result in extrusion, migration, and diastema formation. Microtopography of gingival wall. It has 7 zones. First is the zone of relative quiescence, which is characterized by the presence of moles and depressions and a small epithelial shedding. Second is the zone of bacterial accumulation, which is characterized by the presence of bacteria, rods and cocci within these depressions or moles. Third is the area of emergence of leukocytes. Fourth is the area of neutrophil and bacterial interaction, which results in the phagocytosis and the destruction of these bacteria. Fifth is the area of intense epithelial desquamation. Sixth is area of ulceration, and seventh is the area of hemorrhage, which is characterized by the presence of numerous RBCs. Zones at the bottom of pocket include first the cementum covered by calculus. Second is the area of attached plaque, which ranges about 100 to 200 microns. Third is the area of unattached plaque. Then is the junctional epithelium, which here is 100 microns, but in the normal gingiva is about 500 microns. Then area apical to junctional epithelium. Thank you.